I'd like to echo the sentiments of the other international visitors here and to thank you not only for the extraordinary hospitality that you always show us, but also for these wonderful conversations. I think Lakshmi mentioned that we all have this second job, and I think for many of us it's the vigor of the discussions that happen in a forum like this that keep us going and keep us pursuing that second job. I have no conflicts of interest to declare. Time is precious. Time is money. We know that 70% of the costs or thereabouts of neonatal intensive care are actually the costs that accrue to personnel who are involved. And what that means, especially when we are undertaking something that is as personnel and time intensive as the quality improvement initiatives that we've been discussing this morning, is that we have to choose what initiatives we will undertake very carefully. If we do not, then we will quickly expend our most precious resource chasing down projects that might not or should not perhaps be the highest priority of our unit. So what we're going to talk about today is not the how of quality improvement in this particular talk, but where to direct that particular therapy of quality improvement for your unit. I'll try to keep this as practical as we can. So what sort of elements should we be looking at in deciding what your next quality improvement priority should be? I'm going to talk about four. Some of them are quite common sense, and some of them are more data-driven. But in each case, I hope that I'll be able to show that there is essentially an evidence-based approach to applying them and to choosing a QI priority, a project priority. Let's start with the one that is most common, most traditional, and perhaps most common sense as well for us as clinicians. And that's to use elements like event reporting or what comes out of our morbidity and mortality rounds that happen weekly or monthly, or suggestions from staff. Essentially what we're doing in this case is to use evidence that comes from our colleagues, from staff, and also evidence that comes from patients about what the priorities are locally in our unit. We've taken this one step further in my unit in a fairly simple way by instituting something that we call the Neonatal Care Improvement Opportunity, or NCIS. We have pads of paper that look like this lying around the unit and in the break room, and we encourage our staff in the middle of the night, anytime a problem comes up, to complete one of these and to tack it up on a board in the room where we have our lunch and breaks. And as you see, it includes your name so that we can ask further questions. It includes a description, a brief description of the problem. It asks the person completing it, the staff person, why he or she thinks this is occurring, and also asks them to suggest potential improvements, and then to tell us why they think this is a priority. Is it patient safety, care quality, efficiency, waste, something to do with satisfaction of our families, or something to do with making staff lives easier? And then what people are asked to do is to tack it up, as I said, on a board here. And importantly, these are not just stuck up on a bulletin board, but as we heard from Dr. Diori just now, the key issue is in making sure that there is a response or an involvement of a very rich multidisciplinary team that includes not only individuals at the front line, but also leadership. And so every morning, every weekday morning for the entire year, the directors of the medical staff, of the nursing staff, people at the maternal and infant director level all meet along with frontline RNs and MDs and go over everything that's been pinned to this board and try to decide what sort of a solution is possible. Is it something that can be fixed right away? Is it something that is a longer-term problem? Or, to our purposes today, is this something that should be entered into an ongoing continuous quality improvement initiative where we come up with a SMART aim, as was described by the previous two speakers, and we bring together a multidisciplinary team and we start to use a PDSA, a model for improvement, to attack a problem. Now, every morning, these are actually entered into an email database, and there are updates that are sent out to staff. Your problem has been looked at. This is our plan. Here is where it ranks on the priority list. And so staff immediately have information back about how their suggestions for QI priorities are being dealt with. And what that does is to encourage them to keep submitting. And so every day we'll have 2 or 3 of these, and it really gives us a sense of the priorities or what is happening in the unit. It's very powerful, and even though it's very, very simple, we've gone through now well over 500 of these suggestions over the past year. So that's the simplest way. How about some that rely a little bit more on data? The first approach is to think about variability as being a friend and something that we can use to identify priorities. The first kind of variability is variability that occurs between institutions that we've heard a little bit about. And so in this case, we're looking at evidence from comparing ourselves to others as to what our priorities should be. Many of you have probably seen this quite famous graph that occurred in an article in Pediatrics in 1987 that was under the first authorship of Mary Ellen Avery, one of the founders of our field, as you know. Dr. Avery used to like to tell the story that this actually, the nidus of this was actually a conversation that occurred in an airport with a flight delay when people were, the directors of units were coming back from a conference just like this and started discussing the fact that their mortality rates amongst VLBW patients seemed to be very similar from unit to unit. But lo and behold, the bronchopulmonary dysplasia rates seemed to differ quite substantially. And in plotting this variation, this variability between institutions, it became apparent that one of the institutions had an extremely low rate of BPD as defined by 28-day oxygen requirement. And that, of course, was Columbia Hospital in the US, where they were using CPAP very aggressively, or what was at the time very aggressively. And so it gave a clue as to what sort of, what we could learn, first of all, from a leader in the field, and also what other institutions that had much higher rates of BPD could learn. Now, obviously, interinstitutional variability has become an important part of what we do. This is the incidence of nosocomial infection from the Canadian Neonatal Network, and you can see that the incidence varies from close to 0% or up to over 20%. This is now data that's about 10 years old, so it's a little bit out of date, but you can see that Unit A and M and P might want to think about making nosocomial infection a QI priority, whereas Unit B might be one that could do the teaching around it. It's not only outcomes, it's also therapies, and so this is therapeutic variation amongst moderately preterm infants in a project that we did also at around the same time. And here you can see, for example, that the use of central venous lines in quite large babies, these are 30 to 35 week infants, also varied by a factor of 3 or 4 across the 10 institutions, of which 6 are shown in this slide, that participated in the MPIP project of moderately preterm infants. Now, of course, whenever we see one of these as unit administrators, the first thing that people often say, although it's less often now, is, well, my patients are different. And so it becomes important to think about what can contribute to this variation between institutions. And of course, as you know, it's partly the illness severity of the patients. Part of it is the role of chance, that for some years you might just be unlucky enough to have a high incidence of nosocomial infection. And then if we can take care of those two issues, what is left is presumably differences in the quality or effectiveness of care. So how can we get rid of those other aspects so that we can use variation to drive our QI priorities? Well, the first issue is to think about how to deal with case mix or illness severity. These two infants are from a picture that was taken by one of my colleagues. They are twins. They have the same gestational age and a very similar birth weight, but as you can probably imagine, on the same day of life, one of these has a much higher risk of having all sorts of bad things happen to her than the other baby does. And so that's where this idea of risk adjustment comes in. And risk adjustment, as many of you know, is just a process of thinking about how to compare apples to apples. So if we think that if we consider two hypothetical NICUs, one of which has a 20%, 2 out of 10 incidence of a bad outcome, say mortality, and another unit that has a 40% incidence of a similar bad outcome, then we would obviously say, well, you know, I would want to be in NICU 1. But then if we take those infants and we split them out, maybe according to gestational age or birth weight, maybe we say that amongst infants who are less than 1,500 grams, we have a 50% mortality or 50% bad outcome rate in NICU 1 and a 50% bad outcome rate in NICU 2, and amongst the larger infants, there's a 0% outcome rate. Now we've converted an impression that NICU 1 is a superior sort of NICU into an impression that these are actually equivalently performing sites. So this, all different kinds of risk adjustment basically just do this. Even if they're doing it in a very methodologically sophisticated way, all they're really doing is stratifying so that we can compare apples to apples. The approaches basically fall into several categories: diagnosis, characteristics, therapy, and physiology. Diagnosis is basically saying, well, if there are more patients who have surfactant deficiency, then those patients are probably going to be sicker. We sometimes use birth weight and gestational age, as I just described. We know that intubated patients, for example, are more likely to be sick than non-intubated patients if we walk into a unit. And then obviously if there are abnormalities, derangements of vital signs and laboratory investigations, the more of those there are, the sicker your patients are. There are various advantages and disadvantages of these. Some of them are clinically more relevant. Some of them can be are subjective and can be at the discretion of the people looking at them. Physiologic parameters tend to be a little more predictable, but it's usually, risk adjustment is best done as a combination of these. Many of you are familiar with the score for neonatal acute physiology, which basically takes a number of factors, gives points. The more points you have, the more out of range of a particular factor is, and then you get a score. The higher the score, the sicker that you are. And when we looked across units in the Vermont-Oxford network, there was an amazing amount of variability in illness severity. So those administrators who were saying my patients are sicker than yours were right. In many cases, they are. So that's the measurement of illness severity. Now we need a way to take chance out of the mix as well. And the approach here is basically to start with quantifying risk, just as I described. Do something like a SNAP score or a measurement of a stratification of your babies in some way. We use that to predict risk. We say, okay, if you have a SNAP score of 30, the likelihood of patients the likelihood that your mortality rate or there is a high likelihood that your mortality rate will be, say, 11% amongst those patients. Then we go into the unit and we observe the outcome in your unit. We say, is it in fact 11% or is it something else? And we compare the observed to the predicted. And here's where the chance piece comes in. Basically, in old-fashioned or traditional epidemiology terms, we say, here's the observed morbidity divided by the predicted morbidity, and we just ask ourselves statistically, is that equivalent to 1? Or we can do the difference between them and ask, is this equivalent to 0? We can apply, for example, a chi-squared test to the ratio, and that allows us to decide whether we differ significantly from the average. Here's what Vermont Oxford presents. We've seen this type of a slide already this morning. These are the key performance measures for very low birth weight infants, and you see in this particular unit, which is mine, we have very, very low rates of some things, and our chronic lung disease rate at the time that this was done was quite high. And so we would want to say, after taking into account illness severity and after taking into account chance, we would want to say that any dots that are above the confidence bound or above the range that's shown by these bars across all units in Vermont Oxford, above the 95th percentile, we would want to say maybe that's something that we should be adopting as our QI priority. So this is a data-driven approach to prioritization. This is a slightly more sophisticated version of that graph that also takes into account the size of the units. So, so basically using that approach of measuring risk, predicting outcome based on that, comparing it to observed, and then testing using statistics, we take out chance and illness severity, and we're left with differences in quality, and now you can undertake a QI project. Okay. What's the next approach? It may be, and as we've said, it's difficult in some centers or some settings to be able to compare yourselves to others. But we can always compare ourselves to ourselves, right? And so we can use evidence from comparisons over time to drive our QI priorities. This was an area that was really developed at its basic level, and then marketed over many decades initially by Dr. Walter Sheward, and then later by one of the founders of improvement science, Edward Deming, who I'm sure many of you know about. And the basics is conceptually quite simple. It's the idea that we take some measure. This might be the BPD rate or mortality or nosocomial infection, and we plot it over time. This on the x-axis here we can have any sort of measure of time. It can be 10 patients followed by another 10 patients followed by another 10 patients, or it might be months, for example. The key thing is to plot it in a continuous way. And then this line that you see on all these charts that we're presenting today is basically just the median. And what we can do then is to use this to generate an idea about whether what we're seeing is out of the ordinary. So we know that with heart rate, for example, there's a little bit of a biological variation over time. Sometimes my heart rate is 60 and sometimes it's 70 and 40, and it's moving up and down. That's called common cause variation. It's random variation over time, or something that's driven by something complex and underlying our observation. Special cause variation, in contrast, is where something new is happening to derange a system, to set it out of bounds of what it normally is. So, for example, if I'm coming up to do a talk, my heart rate might go to 100 because I'm nervous. Something has happened. And basically, the magic of what Sheward and Demings derived was a sort of semi-statistical method to tell us when we are dealing with special cause variation versus common cause variation. So what we do is just apply 4 simple rules to that simple chart. So if the dots on your chart shift so that there are several in a row below the median, then that's special cause variation. Something has happened in rule 1 to change things. Or they might all be going in the same direction. 6 or more, or 5 or more dots might be going in the same direction. Something has happened to have that start. And in fact, we know that from a probabilistic standpoint, the chance of that happening is less than 5% if it was a completely random process. There might be too many or too few crosses of the median. There should be a certain amount of variation. That's rule 3. Or where there might be one data point that is just really, really out of whack. And so we can take that simple chart, apply these rules, and if we see something happening, we can say, maybe I'm seeing a trend here. For the last 6 months I've been measuring my BPD rate. It's been going up. Maybe that needs to be the priority for some sort of quality improvement intervention. Similarly, if the median is just not where you want it to be, you can also undertake a QI intervention, but it's usually a different set of tools for one versus the other. I'll just add, as we were thinking about doing these sorts of charts, that there is some danger in just plotting before and after numbers and using that to derive your impressions about QI priorities. So we see here a decrease. Maybe this is the decrease in breastfeeding rates, for example, from a unit of 8, maybe that's percentage or numbers in a month, down to 3. Now, if we convert these to run charts, that could either be driven by a chart that actually looks like this, where there has actually been a shift, where something has happened that is a special cause variation, or it can be from a situation where there's been a long-term decrease over time, or it can be from something like this, where there was a brief derangement and now things are returning to normal. We would launch different sorts of QI interventions with each of these, and we may be misled and go on a wild goose chase. So it's important to plot over time in that direction, or in that way. The last thing I'll deal with is something that I've called frontline consensus, and I'm going to describe to you something that we did at the national level in the United States with the AAP that allowed us to derive a set of quality improvement guidelines. And in this case, what we're using is evidence from a consensus of clinicians and also some evidence from the literature to derive our priorities. This is something called the Choosing Wisely program that was put in place by one of my colleagues, Timmy Ho, and as I said, members of the AAP, along with representatives from IHI and from the Vermont Oxford. So the American Board of Internal Medicine, which is a certifying agency in the United States, said they wanted clinicians to get together and to define some items that should be talked about more, that were questionable and should be talked about more by clinicians, and in this case by patients. And basically this was around waste, but it applies verbatim to what we're talking about today. They said that care that is chosen wisely should be evidence-based, it shouldn't be duplicative, it should be free from harm, as we heard in the last talk, and it should be truly necessary. They let subspecialty organizations like cardiology and pediatrics and so on choose methods. They could be consensus panels, surveys, systematic reviews, but they should generate lists of 5 things each that physicians and patients should question. You can find many of these lists on this website, choosingwisely.org, on there. And the idea was basically to use those at a national level to undertake QI projects. So we surveyed about 3,000 MDs from the American Academy of Pediatrics section on neonatal perinatal medicine, as well as 1,000 individuals who are at the Vermont Oxford Annual Congress. And we asked them this question: if you consider all of the screening and diagnostic tests that were conducted on newborns, can you provide 5 examples of tests that either do not improve patient outcome, there's evidence that it does not improve patient outcome, or there's poor evidence that it improves patient outcome, or that it's resource intensive in an unnecessary way, that it's wasteful. We asked the same question for therapies. Are there therapies for which there's evidence of absence of effect, absence of evidence of effect, or waste? We took those responses. There were about 2,900 responses from the 1,000 respondents who came, who returned the survey electronically, and we put them through an expert panel that represented 28 perinatal care organizations, basically every organization we could think about in the United States at the time, both MD and nursing driven. They used something called a modified Delphi process to vote, essentially, and it works like this. Rather than just getting one vote, you get 100 votes, and you can distribute them across the items in which you're interested in a way that tells us about how strongly you feel about a particular candidate therapy. So we might say, well, I'm not going to put any votes on caffeine because there's good evidence that works. So I don't want it to show up on my top 5 list of things to question. On the other hand, head CT is associated with exposure to radiation, and there are alternatives, so I'm going to put lots on that, and then I'm going to spread my votes amongst some other items, as you see here. Then we had some rules that we applied for deciding whether items would go along to the next stage of assessment. We started out with 22 clusters that involved things like gastroesophageal reflux medications, antibiotics, and so on in certain situations, chest x-rays, and after the first round of voting, we reduced those down to only 14. In the second round, we applied clinical context, so rather than just talking about antibiotics, we talked, for example, about antibiotics for more than 48 hours for asymptomatic infants, or anti-reflux medications for treatment of apnea, etc. After applying the clinical context, we then didn't just rely on the experts to know everything. We did a grade review for the 14 items that were still on our list, and as you heard from Dr. Wright this morning, we developed an evidence summary, tables that looked like this, and gave them to the experts along with a 1-paragraph summary of evidence so that they could make their votes in an informed way. And what we derived with that process was this top 5 list that we were going to roll out nationally, avoiding the routine use of anti-reflux medications, avoiding the routine continuation of antibiotic therapies beyond 48 hours, avoiding daily chest x-rays, avoiding screening MRIs for babies who don't have neurologic risk at term. Now, the interesting thing here, just to wrap up, is that you can take, although we did this at a national level, you can do this with 1 unit, or you can do this with a collection of 3 or 4 units, NICUs that you work with. You just give exactly the same survey to your staff and to your MDs. You ask them to give you ideas. You put all the ideas in a hat, and then you go through a process of selection and voting electronically, or I do this often in person, just by writing on pieces of paper on the wall and having people vote. And then that becomes the priority for quality improvement. So we've seen several different approaches that are driven essentially by evidence from literature, as I just described, choosing wisely, evidence from interinstitutional variability and comparing yourself to others, evidence from a change in your institution over time, comparing to yourself, and evidence from staff and patients, the old-fashioned approach, but probably the one that has the best sense of what's going on in your unit. And then, once you take the priorities, you feed them into the how of quality improvement that we've been talking about. So I hope that gives you some ideas about the sort of conceptual approaches to choosing NICU priorities. And I don't know if we have any time left for questions, but thanks for the extra minute or two.